Today we're going to be reviewing Chapter 16, Nursing Care During Obstetric Procedures. Amniotomy is another term for talking about an artificial rupture of membranes. This is a procedure that can be performed either by a physician or a nurse midwife. Indications of this procedure are to help augment, add to labor, or to induce labor. It allows for intermittent fetal monitoring, as it is not typically a high-risk procedure in terms of high risk for damage to mom or baby. The thought process is behind that artificial rupture of membrane is that once that membrane is broken from baby to the outside world, mom begins to release some prostaglandins, which can really add to the labor that perhaps is already started or kind of initiate labor itself. Risks of artificial rupture of membranes include a prolapsed cord, one of the complications of labor we had discussed in previous weeks, where part of that cord from the fetus kind of comes through the cervix and through the vagina, as well as increased risk of infection and increased risk of abruption of the placenta from the uterine wall, which is followed by heavy vaginal bleeding. So it's important that as labor nurses, we continue to monitor the fluid the patient is leaking, the color, consistency, and the amount so that we can make sure we're maintaining health and safety for our moms and babies. The technique, like I had discussed before, used by a healthcare provider, the amnio hook is kind of a type of a crochet hook, if you will, has a little sharp pointed edge to it that hooks onto the membranes that really help to kind of open up that bag of fluid. Considerations include having that baseline information, how that fetal heart rate is, and then monitoring the fetal heart rate about 20 to 30 minutes both before and after the procedure. Nurses can assist with the procedure by kind of placing some absorbent pads underneath the patient, making sure we have the equipment available, and identifying any kind of risk behaviors for our patients, really kind of promoting comfort. There is no nerves on the bag of membranes, which can cause pain for the patient, but there is nerves in the vagina, so the patients often report the vaginal exam itself as an uncomfortable experience. Artificial methods to stimulate uterine contractions. That's the following thing we'll be discussing a little bit. Induction and augmentation of labor, some indications. So reasons that we would be augmenting or adding to a patient's established labor or inducing their labor could be for reasons of the intrauterine environment. It is no longer an environment that is safe for a growing fetus. If somebody's bag of water breaks, we want to decrease their risk of infection. So perhaps recommending the augmentation or induction of labor could be the best plan of care for a patient. Post-term pregnancy, we know that pregnancies are good for about 42 weeks, and after that we really start to worry about the compromise of the placenta and blood flow. Chorioamnionitis, the inflammation of the amniotic sac and leading to infection there. We know that is a hostile environment for a baby to be exposed to, so those would all be indications for a induction or augmentation. Contraindications for induction and augmentation, we really want to think about blood flow again. So placenta previa, vasoprevia, umbilical cord prolapse, those are all issues with circulation of oxygen and blood supply to the baby. So those would be reasons we do not want to induce a patient. Risks of augmentation include hyperstimulation to that uterus, hypertonic uterine activity, risk of uterine rupture, in particular to patients who have a history of uterine surgery, maternal water intoxication from IV fluid support, greater risk for that chorioamnionitis, so that infection that could happen in the intrapartum period, and a greater risk for cesarean birth. Augmentation techniques include determining when induction is indicated, so the gestational age, always a factor. Very rarely do we want to induce people in a preterm period unless it is unsafe to continue the pregnancy in that setting. We want to perform a cervical assessment, which is called a Bishop score. This score is given to moms based on a vaginal exam to really assess whether their cervix is favorable for the process of induction. A cervix that is favorable for an induction is a cervix that's going to be much more receptive to medications or interventions used to start or add to a labor. We want a cervix to be nice and soft, kind of perhaps even a little bit open, to really be receptive. When a patient has a low Bishop score, they have reported what's an unfavorable or an unripe cervix for induction. So we know those patients are going to be more challenging to induce labor. Cervical ripening methods include both medication management as well as mechanical dilators. Oxytocin could be a method or an intervention that we administer to promote the augmentation of labor, to start the induction of labor. It is medication that is administered through the IV. Typically in each hospital setting, they have their own kind of protocol as to how it is titrated and administered, but it is typically done through the IV using a pump to really get an exact dose of medication, and it is a start slow and go low type of medication. We want to kind of mimic what mom's body is doing in labor, so we start at a low dose and can increase or decrease that dose based on the information we're finding, meaning our contraction pattern and our fetal tolerance of labor. We want to observe the fetal response, especially when we're inducing labor. We want to make sure that we're not creating overstimulation of the uterus itself and causing fetal distress. So it's important that we monitor fetal heart rates, usually throughout the induction process, to see how our passenger is doing. Other considerations is that maternal response. Not only the uterus itself, but we also want to discuss kind of pain management techniques and plans for that for mom as well. We want to assess mom's vital signs. How is she going and doing in that induction process or augmentation process? It's important that just like our med-surg patients, we're assessing their intake and output. We're observing signs of water intoxication. We know these patients are connected to IV fluid as well. We're assessing for uterine atony in the postpartum period. We know that patients who have an induction or augmented labor are at higher risk for postpartum hemorrhage, so we want to make sure that we're safeguarding these patients as well. Aversion. Aversion is the physical movement of a baby on the outside, usually with the provider's hands, to help move this baby in a cephalic presentation. An external version changes the fetal position from breech or shoulder, transverse lie, to an oblique or a cephalic presentation. An internal version changes the position of a second twin in a vaginal birth. So typically what we're seeing are external versions here, and this happens at the bedside, typically unmedicated, but as we can see in slide 15, these patients can have IV access in case of that overstimulation of the uterus there or any signs of fetal distress. In slide 16, we can see that internal version usually occurs with twin B on patients who have twin vaginal deliveries. Contraindications for this: uterine malformations, scarred uterus, so patients who've had previous C-sections, very large for gestational age babies. The babies are greater than 4,000 grams. A present cephalic pelvic disproportion, so we know that these two parts will not kind of meet together and really accommodate a baby of this size in the pelvis. And enlargement of the fetal head, we heard that term before, macrosomia, as well as any issues with the placenta or low fluid that really can cause some fetal intolerance of this procedure, such as oligohydramnios or ruptured membranes. Risks include few risks to mom, but some serious fetal risks do occur, such as the fetal cord may become entangled, which causes severe distress, can cause some issues with circulation and oxygenation of this baby. The placenta may erupt due to trauma from the physical manipulation of the abdomen and having that mixing of fetal and maternal blood. Techniques for aversion usually include that kind of baseline information, such as an NST to be performed. It's usually done either around that 37-week or if not a little bit before or after. Typically, patients are given a tocolytic, such as terbutaline, to help relax that uterus, especially when it comes to any type of manipulation. And healthcare providers are usually using an ultrasound to help guide manipulations. For patients that are Rh negative, they may receive a dose of RhoGAM due to that potential kind of bleeding that may occur. Some considerations including really educating our patients for the procedure that's about to occur, some of that anticipatory guidance, promoting maternal and fetal health and reducing anxiety, discussing, what the procedure might be like, what the patient will experience, what some normal outcomes are. Operative vaginal birth, some indications would be to promote a shortened second stage of labor. Some maternal indications, perhaps there's some maternal factors as to why we do not want this patient having prolonged pushing, such as cardiac disease, and we want to decrease their valsalgia movement, as well as some fetal indications such as fetal distress. Contraindications in an operative vaginal birth include if a cesarean birth is preferable. We want to make sure we have informed consent from our parents prior to instituting any operative vaginal deliveries. We want to assess acute maternal conditions. We do not offer these for high fetal station. I'm talking about high fetal station in the pelvis. We want to make sure that that this is an intervention that will likely work and help that baby be delivered vaginally. Operative vaginal birth risks include trauma to both mom as well as to fetal tissues. Techniques include the preparation for a mom. We want to empty her bladder, create as much space as we possibly can in that area. We want to make sure the cervix is completely dilated, the membranes are ruptured, and that there's adequate anesthesia prior to placing any of these instruments on mom. Classification of techniques include the outlet, meaning that fetal head on the perineum, low edge fetal skull at +2 station, that is ideally where the baby's head will be during an operative vaginal delivery. Forceps are blades, which kind of look like these silver spoons, and they're applied to the fetal head. And a vacuum extractor is kind of a small suction cup with a cotton sponge on the inside that it's attached to the fetal head, and traction is applied in order to promote delivery, especially getting that baby underneath the pubic symphysis. So you can see those illustrations in slide 27 as well as in slide 8. You can see why it's so important to really empty a patient's bladder in both of these images because of the area in which the providers are working with. Considerations include observing mom for trauma after birth, assessing her lochia or her bleeding, making sure that the fundus is firm, observing the neonate for trauma after birth, looking for any type of scarring, cutting, fetal asymmetry on the face. Episiotomy indications can be used for situations such as a shoulder dystocia, where the physical opening of the vagina is needed to widen a little bit in order to accommodate a larger fetus. Vacuum or forceps-assisted births, face presentation, and a preterm fetus where there might be exhibited signs of fetal distress. Risks of an episiotomy, which is kind of the non-surgical cutting of the vaginal opening to create more space, include infection as well as significant perineal pain depending on the area in which it is performed. Medial or midline episiotomy goes kind of straight towards the rectal tissue and can increase the type of tear in the rectal tissue. And a medial lateral is the more common use of an episiotomy, and that does compromise some of the tissue on the lateral side of the vaginal wall, but tries to conserve the tissue in the rectum. Considerations for episiotomy include promote gradual stretching of the perineum during the second stage, such as performing perineal massage, warm compresses towards mom's bottom to really promote that tissue to stretch. Delaying pushing until the urge is felt, and pushing with an open glottis. It's a very different type of pushing where moms are encouraged to kind of grunt or make noises, really kind of bear down, let that tissue stretch there, and observe for any type of hematoma or edema that can occur in that area, in particular the site of the episiotomy. Cesarean birth indications include dystocia, fetal pelvic disproportion, baby's just not coming down into the pelvis well enough, hypertension, other maternal diseases, and active cases of genital herpes. Indications also include previous uterine surgical procedures, persistent fetal distress, which is non-reassuring, prolapsed umbilical cord, as we had discussed, is one of the obstetrical emergencies, malpresentation of the fetus, such as a breech presentation or transverse presentation, and other hemorrhagic conditions in mom. Cesarean birth contraindications include fetal death and a highly immature fetus or non-viable fetus, as well as any maternal coagulation defects. We want to make sure that we're assessing these patients for the risk of bleeding. Maternal risks for a C-section include, it is general surgery, so it does include infection, hemorrhage, urinary tract infection, then that can be related to Foley catheter placement, as well as the having that Foley catheter stay typically in place for a good 24 hours after surgery. Any clots, that's part of why we promote those pneumo boots on patients to really kind of have them start circulating their blood, and oftentimes we will also anticoagulate them postpartum. An ileus, atelectasis, and any complications from anesthesia, which can be either through an epidural or spinal, as well as general anesthesia. The fetus also encounters some risks during a cesarean birth, such as lung immaturity if delivered preterm, transient tachypnea due to the different type of kind of squeezing and removal of fluids that babies have that are born via C-section versus babies that are born via vaginal delivery. These newborns can exhibit persistent pulmonary hypertension, especially if delivered in the preterm period, or any type of traumatic injury. A technique for cesarean birth: patients are prepped, they're consented, the plan for an anesthetic is discussed, they are medicated, patients will have kind of baseline lab values and given prophylactic antibiotics prior to the start of the incision. Their skin is prepped, a Foley catheter is placed, and the surgery kind of proceeds. And typically, the most common incision is that low transverse incision, what we're seeing in slide 40, but for other reasons, for example, extensive maternal uterine surgery, a surgeon might choose to change the line of incision. Skin incisions, typically seeing that low transverse kind of over the bikini area again, but due to other reasons such as extreme prematurity, better visualization of the uterus, other skin incisions might be required, such as that vertical incision that we're seeing in slide 41. Some considerations for our patients undergoing C-sections include, providing emotional support for them, preparing them for the surgery and more painful recovery that they will have. Talking about pre-op teaching, post-op teaching, promoting safety, and providing care to our patients, both in the post, intra, and pre-op periods.